Well, once again, good evening, everyone. Thank you so much for your patience and for working with us as we have more people joining in. Welcome to this edition of Benjamin Rush Institute's virtual event series. My name is Cleo Gama. I'm a third-year medical student at Liberty University College of Osteopathic Medicine, and I'm your host for this evening's program. We have a very special guest with us today, Dr. Jules Madrigal. She's board certified in internal medicine and pediatrics, and she practices in the Highland Lakes area near Austin, Texas. Dr. Madrigal is also a member of Benjamin Rush Institute's board of directors. And before we can begin with her presentation, I'd like to remind you guys of just two quick things. The first one, that we have a chat feature available. So as Dr. Madrigal gives her presentation, if you guys have any questions, we can write them down so we can get back to those questions once her presentation is done. And the second thing is just that to remind everyone, we can keep our microphones mute so she can have a smooth transition through her presentation. And without further ado, Dr. Madrigal, thank you for joining us and welcome to the virtual event series.
Hi, thank you for having me. Okay, so I'm going to talk about how I run my practice. I know that in medical school, you get a lot of information about how to code, about insurances, or you kind of do, you kind of don't, but it's kind of assumed that you're going to take insurance and that you're going to go that route. So my practice is kind of the opposite of that. And the reason I like the Benjamin Rush Institute is because, I don't know if you know, but like Benjamin Rush was one of the founders of the United States. He was a physician, and he really felt strongly even back then that the doctor-patient relationship should be a sacred relationship and that nothing should get in between the doctor and the patient. So when I first started, I took insurance at the very beginning, and right away I knew I didn't want to. I knew that I couldn't do the things I wanted. It was very expensive. There were wait times. There were all these hoops I had to jump through to do what I had learned in medical school. You know, we had learned, like, if a patient has these symptoms, get these tests, and then an insurance company was telling me, no, we can't. So, and a lot of times the people who are making the decisions aren't medically trained. So it was really an unfair place to put the patients in. And there was so much in between what I wanted and what the patient needed that I really wanted to close that gap. So what I did is I just modeled my practice after the doctors that were working a century ago. And actually not even that long ago. I just did it from before there was insurance, and it's worked beautifully. So I've had my practice now. This is my 21st year, and I don't know how it works, but it just does. So I'm going to kind of go through the way I do it. A lot of other doctors do this now. Some of them do like a concierge program. Some of them do fee for service, but I'm not the only one now. When I started, there were hardly any, but at this point, there's a lot of other different kind of models to go from. I'm going to show you mine. So here's Benjamin Rush. I'll let you guys read through that. But it's funny that this was in 1811, and this still definitely holds true today for all the things we have to jump through, all the hoops we have to do, and we're actually just trying to be moral and take care of patients. Okay, so first off, I want to talk about what patients hate about the traditional system. They're not really traditional. What I'm doing is traditional, but what the party line is, so to speak, or what most people do, I think a lot of patients dislike. So I think a lot of patients, they aren't even given a name a lot of times when they check in. They just have a code or a number, and then the patients are treated as their diagnoses, not actually as, Grandma Jones or whatever. So I don't think patients appreciate that. The other thing I see a lot nowadays in the standardized system is that people can't get a second opinion. That is so important, and that's always been one of the things is if you don't know, look harder, or if you don't feel comfortable as a patient, go somewhere else. And a lot of people are in systems where that's just not allowed, and there's not a way to get another opinion. Doesn't mean the first doctor is wrong, but sometimes we think about things that other doctors don't, or we just have a different knowledge base or experience base. And I think it's so important that we keep that going. I also think that a lot of times people they don't even get an answering machine anymore. Actually, they just get in some giant loop of of phone calls. And if you try to call most physicians after hours, they just say, if this is a medical emergency, call 911. That's all it says. So, and again, sometimes, you know, I got a call last night from a mom whose kid didn't want to eat dinner. I'm like, they're 3. It's normal. It's fine. You know, that doesn't need to go to the emergency room. That just needs a doctor to say, it's fine. Sometimes 3-year-olds just have this much of a cracker per day. They're good. I also don't think patients like that an insurance clerk refuses them treatment. I don't even think they understand when I say like, oh, I think you might have an aneurysm. Your insurance won't authorize it. I don't think they even understand that I have to talk to 4 or 5 people to get it when we both know it's a medical emergency. I think they get the idea that somebody's not letting them get it, but I don't think they even understand how devastating it can be. And not just dying while waiting in line for treatment, but like we did have that very case not too long ago with, I really thought somebody had an aneurysm and I couldn't get it approved. So I just said, you know what, if I was you, I would go get it today, because if you do have an aneurysm, you could be dead by tomorrow. And, you know, it's going to take me a week. It's Friday. It'll take me till Monday to get it approved, if they'll do it. If I can even get through the right thing, I've been on hold for 20 minutes. So I think there's a lot about the system that the patients don't like. And I think there's a lot that they don't even know. It doesn't have to be that way. So. Okay, so all these, except for the really obvious ones that aren't, these are all my patients, okay? So it's one of my faves. Okay, so here's what we don't like. Okay, paperwork, tons and tons of paperwork. So most physicians spend about 50% of their time doing paperwork. I spend about 10% of my time doing paperwork, and it's usually reviewing labs. I do occasionally have to do some prior authorizations, but very, very rarely. And usually what I'm actually doing is trying to get free medications for patients who can't afford it through like a drug company program. So that I will do, but like this other stuff, I don't want to do it. It's not helpful for me. It's not helpful for the patient. So I just do my notes when the patient's in the room. And at the end of the day, I zip on home. I don't think most physicians like the uncertainty in healthcare. We don't know. If you take insurance, they can drop your pay at any time. Medicare does this all the time. They decrease the pay for doctors. You don't have a say. If you have a contract with them, you just get what they decide to give you. And once Medicare drops it, all the insurance drops it. Definitely don't like battling insurance companies. I have to do this very little, and it's just, I hate it so much. I just can't imagine if I had to do this every day with every patient. And then just the big hassle factor, all the nonsense computer forms you have to fill out, all the little check marks you have to do to get paid the full amount for each patient, where you have to say that you discussed firearm safety or social interactions, or talk to them about what their pronouns are today to get the full amount of payment, when sometimes those things aren't relevant. Sometimes they are, but sometimes they're not. The prior authorizations, which we talked about, or having to justify to somebody who's uneducated or very undereducated why a patient needs a test. You know, when you have a patient, like I had a patient that's having just projectile vomiting for no reason. She's 15 years old. Her mom had a brain tumor. I wanted to get an MRI of her head to look for a tumor in there that's causing increased intracranial pressure, causing vomiting. But they said, you can't get an MRI of her brain until you do it. But they said, you just can't get it. It doesn't qualify. If she has nausea, she can see GI. You know, I'm like, see, that's just somebody who doesn't understand medicine, you know, and how it could be other things. And we already did a GI workup, but whatever. Also, we don't like to waste time coding visits in order to get reimbursed. That's how big it used to be. It's probably way bigger than that. The Obamacare rules, I don't think I have time to read those. And then just the silly codes. Like, I'm so glad I don't have to do this for everything. Like, I can't believe there's code for being struck by a turtle. Like, for what? Why? And there's a lot more really ridiculous ones. There's a difference between somebody being bit by a parrot versus a toucan, you know? So, and like I said, like I found this code and then I looked it up to see if there's ever been a recorded case of that. And I couldn't find one, but there's a code for it. So it's just a lot of misery added to an already complicated system. And I think the main thing though is not being able to spend enough time with patients. I think that's huge. So many of my friends who work for, companies where they have to see 7 patients an hour or have 7 minutes rather to spend with a patient. It sounds miserable. Today I had a newborn baby. I got to spend a whole hour with her. I just got to hold her and talk to the mom. I'm checking all her reflexes while I'm holding her. The mom and I are bonding. I'm trying to figure out what kind of mom she is. It's so nice just to be able to spend time with the patients, old or young, and figuring out who they are, what medicine means to them, which direction they want to go, conservative or heavy-handed, few tests as possible or every test possible. It's just so nice to be able to do that with these patients. And it's so rewarding. So here's what I do. This is, like you said, all from now on, these are all from office. So I just started out with this hokey little thing, which was teachers and preachers get a discount. I started with that because those were my best referrals. Okay, probably should put beauticians in there too. But the teachers and the preachers give me the best patients, so they get a discount because I think they don't get paid enough. We do completely free visits for patients who get cancer. So if you have cancer, we don't charge you. Usually we do established patients, but if an oncologist says like, oh, I got this person, they could just use you. Maybe they need an antidepressant or they're not sleeping well, or they just need some TLC. We see those people totally for free. Now again, they see their oncologist and use their insurance or whatever for seeing that doctor, but we just see them for free. And that, again, extremely rewarding and amazing to be able to do that. If you take insurance, you can't see people for free. It's against the law. It's considered fraud. So I don't want that. I want to see people for free. We do BOGOs, and BOGOs are buy one, get one free. So because a lot of times I'll have a patient that I don't know if they're going to do well or not. Say they have pneumonia or we had a baby with RSV, and I don't want them to have to pay to come back in because it's me that's going to worry and I'm going to be up all night. So I just do a buy one, get one free, and then nobody has to worry. They can come in the next day or 2 days from now, and I can recheck them, and it makes my life easier and a lot less worry. And it's so nice to do for the patients. We have $5 off if you wear Spurs, just because I like Cowboys and I think it's cool. And patients can call me at home. All my patients have my cell number, and it's been nothing but rewarding to do that. We don't gouge people. Like at my office, you can get a CBC, a complete metabolic panel, a thyroid, and a lipid, and all of that costs $96, including the draw fee. At our local hospital that does charity, it's $1,200 for those same 4 tests. So, and I still make money off of the labs. So, and I feel like I make a good amount of money off the labs, but we don't have to gouge people. We can actually charge them a reasonable and fair amount, which is also nice because if they want a certain test, I can get it and they can afford it. We do a lot of the genetic testing for hemochromatosis because the other doctors say your insurance won't cover and it's really expensive. It's actually not. It's about $100. We charge $125. Done. So, and then every patient's a VIP. Again, if you sat down for them an hour the first time you met them, or you actually get to know them, they really are important to you and they feel it. And it definitely goes both ways. I do house calls and reverse house calls. So this little boy is going to be the bane of my existence. So this was last week, actually. He had already been in the hospital. He got discharged from the hospital. He had COVID and RSV. I just had COVID. That's why I'm not wearing a mask. We're like brother and sister here. So I was like, you know what? I said, he's probably need to go back in the hospital, but just come over to my house on the way. So they came over. I did a breathing treatment. He did great. So that saved all of us. Like, I don't have to worry all night. Mom doesn't have to go to the hospital. Here he is, like a few days later. It looks like $1 million. So, and then I get to take care of the community, like whatever that means. Like, again, back to the cowboy people, cowboy and cowgirls. But it's just nice that, like, wait, you're on your way to a rodeo and you want to let your horse out? Why, of course, let your horse out in front of my office. Like, I just don't think other doctors get this, and I just think it's the coolest thing ever. The reason I think this works, or I know it works, is because people get to choose where their healthcare dollars go, right? I have to be good if people are going to come see me. They're not going to pay cash if they already have insurance, or even if they don't have insurance, they're not going to pay their hard-earned dollars if I don't do a good job. And then we decide together, like, you've been having headaches for a while. You're really worried about it. I can get an MRI of your brain. This is how much it's going to cost. What do you think risk versus benefits are? You know, or the other way around. I'm like, you definitely need this, and here's why. But I really like that the patients are involved in the decision-making process, and we decide together. The way my practice goes, I've seen billionaires and I see migrant workers. Everybody gets top level care. Everybody gets top level treatment. You know, I see a lot of Hispanics. I see a lot of Spanish speakers, and a lot of times those people are really underserved by the medical community. A lot of times I'm like, have you had a colonoscopy? And they're like, nobody ever even offered me one. I know they didn't because they work construction and they think they don't have enough money for it. That's not fair. Give the patients the opportunity to decide if they want that or not. Explain why I want a colonoscopy, right? And I would say about 80% of our patients get it, even if they pay cash, which is way more than people who take insurance have. And going back to the whole Benjamin Rush thing, there's not an outside organization that stands to profit or lose money if the patient gets less care, right? So if you are an entity that works for a big insurance company, there's a lot of pressure on you to do less to spend less. And again, I don't have to worry about that. So my incentive is just to take care of the person who pays my bill, which is this patient. Well, she probably didn't, but you know, she looks concerned. The reason I love this, okay, first I have to tell you, this lady painted this shrine in my office just because I didn't charge her and she couldn't afford to pay. So she painted this for me. And it was a tribute to one of my patients who had died, who I was really close to. Well, then this lady actually ended up getting undifferentiated carcinoma. Nobody ever figured out what the cause was. And this is her, like, probably a week before she died. But it's just a cool place, you know? Like, I feel like she was pretty grateful, and I was really grateful to her. So it works well because there's less staff. I don't have to have a bunch of people on the phone doing prior auths, submitting claims, fixing my codes. I don't have accounts receivable. You know, you pay when you leave, whatever money's in the drawer at the end of the day goes to the bank. That's it. I mean, it's super simple. There's a lot less paperwork, and then my time is spent on patient care, not paperwork, not filling out forms, not going through checklists, nothing like that. And that makes a big difference. The other thing is, like, going back to payment, is if somebody's really difficult, I can charge them more. I don't have to document a reason they're a level 4 or a level 5. I can just be like, this person always gives my staff grief, or, you know, or this person is really easy, or this person's having a really bad day. I want to charge them less. I can adjust that as I need, and I'm not breaking any rules or any laws. I don't have to worry about it being fraudulent. If I feel like charging more for a good reason or charging less for a good reason. Well, it doesn't even have to be a good reason, honestly, but it is. So here's what we do love, right? We love spending time with our patients. So this guy died of cancer about a month after this picture, but again, we're seeing these people for free and we're loving on them. Like, we are really loving on them, you know? And we still, then his wife ended up dying shortly after him. And now I see all his kids, and I get it. I get that they need an extra parent a little bit. And it's really nice to be able to be that person for them. You know, one of them just had a baby. I'm like, I can be the abuela. Like, call me if you need me. We like taking care of the whole family. You know, I'm not family practice, but I am. I mean, I take care of this whole family. And they like me. We like taking care of the easy patients and the non-compliant ones. And again, I just think it's so much easier in this setting. Even the people who are non-compliant, I still love them, and I don't get as frustrated as I used to when I worked for an organization where they wouldn't hit any of the check boxes for diabetes or whatever. This guy probably eats too much cookies. And we love being able to love on our patients. And again, I think this is missing in big medicine nowadays. And I love being able to love these kids and these adults too. But I like that there's a real connection in my office with these people. This is just a cute baby. And there's the mural back there. And I like that I'm part of their lives. Like, I really am. And I like letting my patients love me back. So I get a lot of eggs. Is my visit worth 4 cartons of eggs? Probably not, right? I could probably buy those for way cheaper. But is it worth the exchange? Absolutely. You know, what have I gotten? Chickens, emus, babysitting, dry cleaning, my house painted, my car cleaned. I mean, that's very rewarding. And sometimes, you know, sometimes people say I can't pay. And I say, everybody can do something, and they'll come up with something. I've had a guy made me stained glass. I didn't know I liked stained glass. I love stained glass. You know, it's really amazing when you can do that. The chickens were probably a bit much, but whatever. Oh, I got a goat and 2 sheep one time. I like empowering the patients. I have this picture here because one of my patients who's paraplegic gets recurrent bladder infections. So he knows how much it costs for a UA dip, a culture, a micro, and a CNS. So he just comes in, leaves that, puts the money there. I know it's his. But they're part of my practice. I also love being able to improvise. And during COVID, this was so important. It was so nice to be able to go in people's cars. I'm only 5 feet tall, so I have to like climb up into a truck. But to be able to run this practice and get the system down, we had such a good system for testing, for getting people in. And then when we had the worst happen, like this girl here on the right, like she ended up getting really bad with COVID. She told me I could put her picture in here. She ended up getting really, really, really sick. And she came into the office. Her stats were in the 60s, called EMS. They said, everybody's got the same boat right now. We don't have an ambulance for another hour. I'm like, whoa. Call the local oxygen place, get oxygen sent over, do a breathing treatment. I know we're not supposed to, I don't care. I'm a doctor. I'm okay giving breathing treatments with COVID. Opened the windows, had fans on, gave her the breathing treatment, gave her IV fluids, did oxygen. Then we sent her to the ER. So we spiffed her up and then sent her. Oh, we called the ER too because we were going to send her by POV. And the ER is like, it's a 6-hour wait. There's no way I can see her. I don't care what her stats are unless they're 0. I'm not seeing her for 6 hours. He's like, I'm not telling you not to send her here. I'm just telling you it's going to be a wait no matter what. There's lots of people way worse than her. So it was nice to be able to have a mini ER, not what I would have wanted. I wouldn't wish that on anybody, but I could do it. You know, I can do it. I can get stuff. I can make stuff happen if I need to. I also think it's a very happy work environment. We do TikTok challenges on Fridays. But again, probably if I worked at a big company, they wouldn't let me do that. I also get to be such a part of their lives that I have 3 kids that are named after me. Okay, so the little one that looks super grumpy is this same one. And oh my goodness. So my name's Juliet, my real name. So it doesn't translate into Spanish well. It's Julieta, which is kind of ugly. So I think, but that's my name. So they named her Juliet with a G, so it would sound prettier. And then there's no A on the end. So, but how cool is that? And there's baby Jules. And then this is the youngest of 12 kids, and her name is Juliet, and she goes by Jules. So like this kid, she's the youngest of 12. All the other 12 are like super compliant, just right, straight and narrow. This one at 3 years old was on the roof. So she's following in my footsteps quite well. I like being able to help wherever. I think because of the kind of doctor I am in the office, I'm a doctor all the time. If I'm in Peru and somebody falls down dead, I'm just as much a doctor as I am when I'm in my office. I love being a doctor all the time. We go to a lot of school and I want to be that person that's there for others. I'm also very bossy in any language, evidently. I'm always first on the scene. So, but which is kind of why I went into medicine in the first place, but it is what it is. And again, I like keeping my skill set up. I'm able to do that because of my job, and I keep my skill sets up. So then if there is an accident, boom, I'm there and I know what I'm doing. And I get out of the way when the real people come usually, except that some of these are my people. So they're like, Doc, come on. And one of these, this top one up here, I drove by and the police were there and I was like, hey, are you guys good? He's like, we're good. I went a little further. I was like, hey, Missy, Ricky told me you guys were good. She's like, we're not good. Get your butt out here and help us. I'm like, okay. But I love that. I absolutely love that. And then like the county judge calls me later. He goes, I heard you were in the back of the ambulance crawling around like a spider monkey. I'm like, yes, sir, I was. I love that I can do that. I also love that in our office, we do whatever it takes. So this little bitty one he's the 5th kid. Mom had a bad migraine. Mom was exhausted. So we just put mom in the back room and we all took turns holding this baby and taking care of this little one. That's our lunch where he's down in his little thing. We took care of him and just let her sleep. Because when she fell asleep, I was like, we're leaving her there. We left her there 6 hours. That baby was fine. She was so much better when she woke up. That she was like, this is the first time I've slept 6 hours since I had him. I'm like, we got you. And we all love babies, so it works out. We also don't even mind dragging our kids. Like, I know that the kind of lifestyle I lead does bleed over into my family. I absolutely know that, but I feel like it's a good sacrifice for my kids. Yes, this is a hospital waiting room, you know, in the middle of the night, but I did this on purpose too. You know, one of my really good patients was having a baby. We knew the baby was going to have problems. I wanted to be there when the baby was born. I also really wanted my 16-year-old and my 14-year-old to see what it was like for a baby being born. Great birth control, but also really nice that they understand the importance of being there for other people. That's right when the baby was born. That's her last week. And I like that with my kids, I can carry on the legacy of caring for others. You know, my daughter actually, you've seen a few pictures of her probably already, but she works at my office when she's not in college. And it's been a beautiful thing, you know, I tell them, and you guys know this too, when you make a commitment to taking care of other people, sometimes you see things that you can't ever unsee, but it's also amazing and liberating when you can take care of people at their very worst. And then we also, at my house, we also do, because I think it's important to give back and I get so much from my patients, we also do foster. So this is an emergency foster we had of a newborn. We kept him for 48 hours because his mom tested positive for marijuana, which is a whole nother story. But so we kept him for 2 days until she tested clean. I also do regular old foster kids. This for the one with my jacket on. I stopped in an accident. I had to leave her in my car and have somebody else watch her while I was taking care of the person. And the whole time, and this is a kid who has been raised in a difficult environment. The whole time in the back of her car seat, she's screaming, I want to help. So it's pretty amazing. Look at her feet. Can you see her tan lines from her little flip-flops? That's not dirt. That's just her little tan. She's an outdoor baby when I got her. So this is right when I got her, actually. This is, these are my other foster kids. That one in the middle where the slippers are, that little bag is all that kid had. That is all her possessions when she came to me. So these kids need us. And if you have it in your heart to do it, it's amazing to be able to. And like, we do make good money as physicians. I make good money And there's nothing I would rather spend my money on than other people and other kids. The kid under the Statue of Liberty, I still pay for her college expenses. Kids who are in a foster in Texas get free college tuition, but I still pay for some of Courtney's stuff. I still keep it. My other one this middle one went to beauty school, in case you can't tell. That was prom, actually. And this other one I'm still in contact with. I just had her a few months ago. But I can't think of anything I'd rather do with money than help these kiddos. And there's the 4-year-old when she actually got adopted. She looks exactly like her adopted family. It's so crazy. I mean, what a funny coincidence, but amazing. I actually just saw her a couple months ago. And I also love that we can be that person and be that pillar of community. So this is a nonprofit that I started. I'm the president of, that does flying trapeze, because that's my gig. And we fly kids who are in foster care, underserved, have emotional issues, autism, low-level autism. And we do this just to teach them how to trust people, how to do something amazing that no one else can do. So, but you be you. Not everybody has to do foster, but I think you should do something. And I also love that with this practice, I have a time to do these things. I have time to really enjoy my life. I have time to travel a lot, which really recharges me. And I have time to foster. So in closing, that's in Costa Rica. In closing, I think it's really, really important to just have that doctor-patient relationship, to find that joy. And it is so fun to work with patients every single day. Every single day, I enjoy going to work. Every single day, I feel like I'm doing good. Every single day, I feel like I'm doing what I was put on this planet to do. It's not trapeze. It's taking care of other people. It's doctoring and having those true relationships between the patient and the doctor, and nothing in between. So cute. All right, you guys, questions?
Well, Dr. Madrigal, thank you so much for your presentation. I wasn't even expecting to get so emotional at times. Those are beautiful pictures of all that you do and the people that you take care of. I believe that through the chat option, the feature that we have, people can ask their questions, and once they get to me, I'm going to read them to you. Just got one. So why do medical schools not teach different type of practices that can engage in patients the way that you do?
I don't know. I was actually talking to one of my friends about this last night. I don't know. I think because traditionally when you do your residency and you go through practice, you are working already for a system. And I think they feel like you have to pay back and work through a system for the rest of your life.
Yeah, that's tough.
Yeah, but I don't think it's fair. I went to my alma mater and I gave a similar talk. I actually gave one more based on financials. And my old attending physician, stood up and said, this isn't a good idea. This will never work. And this is not, we don't even think this is moral. And I was like, wait, what? So I just think that, I don't know. I don't know if they just don't want you to know, if they don't know, if they don't believe it. But they don't teach it, and they should, and again, even I don't like concierge medicine because I did it for a very short period of time. I've done it with a few people, and I felt like if they didn't use it, I felt like I owed them. So then like 6 months later, they're like, hey, my contract expired, but I never used it before. And I'm like, I'll just see you for free, and you can't make money if you do it that way. So I just like eating what I kill. So I enjoy just doing, if I work harder, I make more. If I don't, I don't. So I don't like concierge, but there's nothing wrong with that. Some of my great friends do that. And I think that's a great way to do it too. But I wish they would teach you guys other ways of practice. And mine is so easy. I mean, when I started it, I'm like, how much does the average doctor make? How much do I want to make? And I wanted to make that same amount. Now I actually make way more. But how much do I want to make? How many patients can I see a day? In the beginning it was 10, now it's 20, and divide that out. That's all I did. And that's how much I charge per patient. So it's super simple.
Yeah, that doesn't seem so complicated. I wish we could learn that from medical school and residency going forward.
Yeah, like I said, it's really simple. I mean, it's just simple math. So
I have another question that just came here. Oh,
Mhm.
sorry, I didn't mean to interrupt you.
No,
Please.
you're fine.
So
I have a lot of junk behind me. Just ignore that.
Okay, you're good. I'm trying to wrap my head around it. How does a doctor in family practice or specialty care get reimbursed if they do not approach things through insurance? What does the non-insurance process look like?
Okay, so again, super simple. Okay, so like if I see like a kid with strep throat, it's like $75. And then if I do a strep test, it's $25. So when they check out, that'll be $100. It's way cheaper than me getting my hair done. So, and again, then if I don't feel comfortable about the kid, I may say, hey, come back in 2 days and make sure that the amoxicillin's working. So it's just super simple like that.
Wow, that's really encouraging. And for me, I have been thinking about primary care for a while, and especially after your thought, I'm actually a lot more encouraged to pursue the route than I was before. And I really appreciate your time. I have a question of myself while I'm still getting questions from other people. And it's easy to see how clear you thrive in the patient-doctor relationship and having all the pictures of your patients and everyone so happy and smiling. And I'm sure they love you as much as you love them. What do you think are steps that we can take? I know some of us are medical students now, but as residents and as physicians, so we can nurture the same type of relationships, I guess, fighting against the system, but how can we go above and beyond to thrive like you do?
I think just remembering that everybody is really a person and not giving into the system, not giving into the idea that you have to be a certain way. I know in residency you do a little bit, but like in my practice, I am definitely my most authentic self. Like every October, I have pink hair for breast cancer awareness, but I can do that. In a small town, it's a little bit easier because they're a little more accepting. I know it seems like it would be the opposite, but they're not, But that being said, I think remembering that people are people. One of the things that helped me, and this is just a funny little thing, but one of my friends owns a camp, and they have a motto like everybody's somebody here, and he remembers everybody's thing, whatever it is. So when I was in residency, when I had my, you do the little clinics on the side, your primary care clinics, I would write down little notes in there and be like, no children, dog Bingo is her best friend. So every time she came in, I'd be like, how's Bingo? So, and I started it as almost like a trick where I would just put in like little funny things to remember about people. And now it just comes so naturally. Now I remember their grandkids, their dogs, their cats, that they like to swing dance, now it comes really simple. But in the beginning, I had to take notes and do that. But golly, even in residency, and those patients, a lot of them were homeless. A lot of them didn't have, anything. And just them knowing that you actually cared and remembered stuff about them is huge. So I think if you can start that way, then it builds on its own. And then it's really simple. But, and that's what I've had people call me in the middle of the night from cruises, and, they were having chest pain, and I could tell the doctor their medicine's just from my head, because you start to know them so well. We had a patient last month, and he was doing these zone out things. So that they were evaluating him for ADD. And I was like, I don't know if he knows this, but I take care of his cousin, and she has absent seizures. So I'm like, So I get to cheat, right? So then I worked him up for a seizure disorder. He has the same thing, but I think if they had gone somewhere else and said, we think he has ADD, he just zones out sometimes in class and his grades are horrible and the teachers are mad at him, I think they would have put him on Adderall, which would have made that way worse. So I think just seeing the people as people and looking at the whole picture instead of just the disease process makes things click a lot better. And then it just gets easier and easier.
Well, thank you so much. Thank you so much for that. It seems so clear when you're talking about it.
It is. It's like I said, it's super simple. It really is. And Like in my little town, a lot of the doctors that do take insurance will send me really difficult patients. I'm not smarter than them. I just have a lot more time than they do, right? So, and I can order any of the tests I want. I can order an MRI of the brain. I can order weird, prolactin level without a reason, right? I can do funny things like that. So it looks like I'm smarter, but I'm not. I just have more time and more resources. Strangely, with less payment, I have more resources.
Oh, that is interesting for sure. Thank you for honestly just sharing that. I'm sure it clears a lot of questions for many of us watching. Another question that came my way is, do you find that most of your panel of patients are from higher socioeconomic groups? Do you find that patients from lower socioeconomic groups cannot afford to see you and can only afford somewhere that takes insurance?
No, most mine are, honestly, if you did the math, it's probably just smack dab in the middle. But volume wise, I probably have more people on the lower end. I probably see more Hispanic construction worker kind of families. And again, we really try to take good care of that group. I'm Hispanic and I feel like they're way underserved. And I feel like if they go somewhere else, they don't get the care and they don't get the opportunities for care. So again, I probably cater to them a bit much, but no, I would say definitely not. We do have some wealthy patients. We have some very wealthy patients that like that they can call a doctor 24/7, and that's awesome also. But again, we treat them the exact same way. But I personally prefer taking care of people middle class or lower because I feel like I'm doing more good. That's where I came from. So I'm just more comfortable with that. I'm not that good with entitled people, and I don't know how to kiss butt very well. So I just like taking care of people. But to answer your questions, definitely. And we make it affordable. Like I said, I think almost everybody can afford $75 for a sick visit, and we try to, like if they're doing really well on like their diabetes, I'll give them a discount. If their hemoglobin A1C is less than 6.5 or less, I give them a discount. And if people are sometimes people come in and they've had some tragedy, we're like, don't pay, you're fine. And I don't even make them owe us because I don't want accounts receivable. I'm like, just don't pay. This is my 21st year in practice. How it works, don't know, but it actually works. So, and again, I think, are those people grateful? Yeah, absolutely. And when they do get money, will they come back? One guy was like that and he just dropped off $25 and told us to get lunch today. That's pretty nice.
Yeah. And I think going along with what you're saying, I know there's a trend now with DPC and it's so cool. And a lot of people are jumping into DPC and charging a monthly membership. It sounds like that's not what you do. Do you have a different approach, and could you expand a little bit on that?
Yeah, like I said, I just have people, pay just for the visit and the labs or whatever we do, and like that's all. So like I said, if you require more time, I charge you a little bit more. If you need lab, I charge for the lab. But I just have people pay for what they use. Again, I don't like the other way because personally it would hurt. I have a gym membership and if I don't go, I feel guilty, and I don't want them to feel like that. And some of our patients couldn't afford to pay a monthly fee. That's for sure, but they can afford to pay when they get sick, or they can round up stuff together with friends and family. And we give them a discount, we make it work. So again, I like to eat what I kill. If I don't like to, again, I understand the model and I think it's great to have a known amount of income. That sounds amazing, but mine's worked out for 21 years. I've been able to take care of 20 children. So it's worked.
Absolutely. We just had a really interesting question. So through direct primary care, how can more recently graduated doctors just out of residency serve the underserved, especially in rural areas? Is this financially feasible, especially with the heavy student debt load?
Okay, so that's what I did. So I started out in the emergency room and I worked there for like 3 months, and I was getting very frustrated because I didn't know what happened to people. And I was scared that I was killing them, or, that something was happening. I wanted to know what happened to them. So I decided to open my own practice, and I thought I would just do it part-time. So I just rented this little sleeve of like 3 offices from this doctor who was well established, and he would give me a spillovers, and a lot of the people from the emergency room hadn't met me would come in. And in the beginning, I didn't even know how to take money, so I only took, like, my first payment was a candle. And in the beginning, I had 1 otoscope, a stethoscope, and that's it. And then I would sometimes liberate some tongue depressors from the emergency room, and then somebody paid me $75 for a visit, so that I bought tongue depressors, and so I just did it super slowly. And in a small town, in a rural area where people are underserved, they don't care if you have a big screen TV or an aquarium in the waiting room. They just want, we have books, and we have signs up that, like, read books instead of be on your things, right? Books are cheap. But I think I just started really slow. I didn't have an interior decorator. My office is pretty basic. The patients don't care, So, and then slowly I would just pay myself first and then go back a little at a time until I made that income. So I was in the black within 3 months, which was really amazing. And then I paid off all my student loans within 3 years. Now, I'm very conservative. And again, I come from a poor background. So I didn't have a ginormous mansion. I didn't have a new car. I do now, but I think, but maybe you wouldn't, but I think, but I just started really slow and just did it just like you would do anything in, money out. Don't take out loans, pay off your loans, go forward. So I think it's very feasible. And again, you get what you work for. A lot of doctors don't get, they'll, like with Medicaid, you may only make $35, and that, or they get, Medicare gets charged $150, but then the doctor only sees 25. Like, that's not fair. We're the ones doing the work. The administrators get paid. Everybody else gets paid. You don't get paid till the end, whatever down at the bottom. So it's been very lucrative for me. And I know I'm the cheapest game in town. And I purposely do that. Like, I know how much it costs for my patients to pay cash elsewhere, and I will always be the cheapest place for them.
Wow, that's awesome. Do you think, would it be easier for someone to start out of residency than start getting a job? Not to say that, like, once you get a job with someone, like, it's impossible for you to open your own thing, but you think, like, there's a greater temptation now that you've been living on residency salary for so long, and now you see more money than you ever thought, than to take your bets and your chances to open something without the certain, like, it's so unsure now. Like, how is this transition? Do you think, like, if you were to advise someone who is under your wings and look up to you, would you advise someone to start straight out of residency if possible, or like doing what you did, have a part-time if needed to, then get yourself a job somewhere, pay your loans, and once you're established and more comfortable, then open your practice? I
think in the beginning, if I'm a person that always likes to have a backup plan, I am not a risk taker. That's why I'm internal medicine, right? So I think having a backup plan is good. I think, like, starting off in the emergency room, I was going to keep working in the emergency room for a year. Just my practice built so quickly that there was no reason for it. I had a couch in my office in the back, so I could take a nap because I didn't think I'd have very many patients. I did that one day. That's it. Wow. So, but I think having a backup plan. I also worked part-time at a rural clinic for that first few months. I'm still the medical director for the fire department. That doesn't pay very much, but I had a few extra things because I had a stay-at-home husband, so I didn't have somebody else whose income I could even depend on to be there. So I like having a few different things, always just in case, but I totally think it's the way to go, because if you start out with a company or you start out taking insurance, it's 3 months until you get reimbursed. And, like, I couldn't do that. I had another doctor ask me to join him, and I'm like, I can't not get paid for 3 months. My kids will starve to death. So
I got a couple more questions, if that's okay.
yeah, as many as you guys want.
Do you think you attract patients who are less complex versus more medically complex patients?
No, just the opposite. So I definitely have but again, I'm internal medicine, and I do think when you start a practice like this, you attract where you are. So if you're a person, so I get a lot of emergencies, which is true in a small town because I ain't going to go no ER, okay? But I like emergencies and urgencies. So I get a lot of those, and I get a ton of the very difficult consults. So I get a lot of people who have really difficult cases. Like we had this lady who had hives over and over and over. She had been to an allergist. She had been to a dermatologist. She had, had all this. And I was like, I'm going to tell you right now, I've seen this so many times. It's probably going to be a cancer somewhere. Let's go find it. So I did my exam. I found this little dark place in her eye. I was like, I'm going to work that up for melanoma. That's what it turned out to be. So again, I just have more time so I can find the cool stuff. But I definitely have that reputation as being the Dr. House without the cane or the drug addiction. So, but I get to be that person in my town. And again, that's what I like. That's what I like about internal medicine. But I definitely get the more difficult cases. I get the babies with the heart defects. I get the cystic fibrosis kids. And again, they have pulmonologists, they have cardiologists, but I get the complicated ones because I can do it, right? And I think I counted the other day, I think we have 45 doctors as patients. Like I get the doctors, they're not easy. They're the worst compliant ones, but that's what I like. And so that's what I get. But some days I would love to be like, can I just have like 5 strep throats today? That would be so great. Maybe 1 UTI, but I don't get those. So
that's hilarious. I think doctors must be pretty difficult patients.
Oh, they're the worst. And veterinarians are the other, just horrible. You gave yourself what? We don't use that in humans. No.
That's hilarious. I never thought about it.
Oh, they're the worst. So.
And we have one more question. How does someone find a residency program that is within the direct primary care community?
You're not going to, but you can find a residency program that, not that I know of anyway. I know family practice does sometimes have that. I mean, I did a university model residency, which is probably what most of you are going to do. I know there are some private residencies out there. I'm just not very familiar with them. What I would recommend is you do a university model because you get this high level of education, and then you go to one that lets you do different rotations with different types of doctors. So you see somebody who does a concierge, that you see somebody who does fee for service, that you see different types of practices. Like we just had a kid your age, come in, and she was doing pediatrics. And she just started crying. I was like, why are you crying? And she said, because the other clinics I've been to, they hold the babies down, they strong arm them, the babies are crying the whole time, you can't get a good exam, and you guys are just playing with them and like snuggling them, and she's like you're not doing checklists, you just take. I was like, I am doing the checklist, but I'm doing it in my head. There's the moral response, fence repose, like I'm doing it all with, I'm doing it. But I think it's good to see different ways of doing it. One of my friends is a high volume person. She like booms them out. She likes doing pediatrics in that type of environment. She's like, I can see 50 people in a day. I love it. That's cool. That's fine. It takes all of us, and back to kind of what you were saying earlier about like starting out of residency, you do need to know yourself. Because again, you're going to attract where you are. If you are a person that isn't really interpersonal with people, you don't like a lot of people, this may not be for you. Like I have had some really shy residents who are really quiet and who aren't very socially connected. And like my practice started because I worked in the emergency room. I had kids that somebody would sneeze when I'm picking up the kids from daycare. I was like, I know a really good pediatrician, so you do have to do some self-selling and, be a person who goes to church, who is involved in things, who's around if you want to get patients. That way you do kind of have to sell it. So my first degree was in advertising, so go figure. But I never did any ads, but I find it self-promoting in case you can't tell.
Well, thank you so much, Dr. Madrigal. I want to be respectful of your times. I am personally a big fan of yours. I've been watching some of yours talks and for quite some time, and I just love your personality, the way that you care for people, and I can say for myself, you're an inspiration to me.
Thank you.
I am really honored to get to talk to you.
Well, follow in my footsteps. That would be the biggest honor.
I promise I will do my best to. That's what I'm intending from the beginning.
Good.
Yeah. So I don't know if anyone has any more questions, but like with the interest of being respectful of your time, I would like to, if you guys have any more questions, just send your questions to Chris at Benjamin Rush Institute. And if you guys would also like to learn more about Benjamin Rush Institute, you can also just forward to the same email address. The next edition of our virtual event series will feature Dr. Daniel Clearfield on October 20 at 6:30 Central Time. Dr. Clearfield is an expert in sports medicine and has worked in the Olympics as a physician for different professional athletes. Please make sure you register. I just see in the chat now, you can use the link in the chat to register for the upcoming event. And I just wanted to thank you all for attending. And Dr. Madrigal, I cannot thank you enough for sharing
Thank
your
you for
time
having
and
me.
your experience. Thank you. I look forward to having you guys again and participate once we meet Dr. Clearfield. And I'll see you guys then.